This is the second half of the lecture on diagnostic imaging of the jaw. Let's discuss fibro-osseous lesions of the jaw. This overlaps substantially with our discussion of fibro-osseous lesions of the sinuses. We'll talk about fibrous dysplasia, then we'll run through the word salad of ossifying fibroma, fibrous osteoma, and osteochondroma. And then we'll talk about something unique to the jaw, the cemento-osseous dysplasia. You can think about it as the corollary of fibrous dysplasia affecting the region of the teeth. There are exostoses that occur exclusively from the jaw, called Torus malformations, and there are enostoses, that is bone within bone, and these are just bone islands as you'd see in any bone. Paget's disease may affect the jaw, although it more commonly affects the skull and skull base, and Langerhans cell histiocytosis is always a consideration for an erosive bone lesion in children. Fibrous dysplasia has three basic forms on CT. There is the classic ground glass appearance as depicted here, but there is also a cystic appearance as depicted here, and then there is a pagetoid appearance, which, as you might expect, looks like Paget's disease. These different forms, imaging forms of the disease, are often seen simultaneously within a single lesion, admixed together. The key to diagnosing fibrous dysplasia is that the affected bone is expanded but retains its normal underlying configuration. Yes, this is a clearly abnormal expanded bone, but it still has the shape, the overall basic shape of a mandible. And that's why we are confident this is fibrous dysplasia. The maintained configuration in the face of the expansion plus the ground glass matrix leads us to a specific diagnosis of fibrous dysplasia. An ossifying fibroma looks a lot like fibrous dysplasia histopathologically, but it looks different on imaging. Instead of having expansion of the bone that maintains the normal configuration, an ossifying fibroma expands like a sphere. This does not have the configuration of the underlying maxilla. It is spherical in configuration. It also has a very characteristic pattern of calcification. This isn't always present, but it's a great clue when it is. It's called a stellate pattern of ossification, and it looks like radiating lines of calcification coming out from the center of the lesion. It can have a lot of the same ground glass appearance that fibrous dysplasia has, as well as, or along with, this stellate appearance. It's the configuration that distinguishes an ossifying fibroma from fibrous dysplasia. Ossifying fibromas come in a more aggressive juvenile form and a more benign adult form. When someone says the word osteoma, you probably think about a uniformly dense mass that's the same density as cortical bone, and most osteomas are like that. We call those ivory osteomas. But there is another type of osteoma, the fibrous osteoma, that does not have a uniform density. It has a heterogeneous intermediate density, clearly got calcified matrix, but a heterogeneous overall density. These are fibrous osteomas. The nasal cavity is a common location for these, and they often extend up or down from the jaw. Osteochondromas can affect the jaw as they can any other bone. The key to the diagnosis of osteochondroma is noticing that this exostosis has a continuous trabecular pattern with the underlying bone, as though the trabeculae are just flowing right into it, and then it blossoms out in a cauliflower or cotton configuration off of the underlying bone. So this is a classic appearance of osteochondroma, just in a weird location. The exostosis that we associate most commonly with the jaw is the Torus malformation. The most common of the Torus malformation is the Torus palatini, which extends inferior like a keel from the center of the hard palate. This is most common in middle-aged females. And these exostoses have no real clinical manifestations until you try to fit dentures. You can imagine trying to fit dentures on this jaw would be difficult. In addition to the Torus palatini, this particular patient has an exostosis coming medially off of the maxilla. That's a Torus maxillaris. So this is Torus palatini et maxillaris. This can also occur usually along the lingual surface of the mandible, and there it is a Torus mandibularis. This is the characteristic appearance of a Torus mandibularis, usually along the lingual surface. Occasionally we see this along the buccal surface of the mandible. Again, no clinical repercussions until you try to put dentures on these patients. A bone island can occur in the jaw as it can in other bones, and it looks like a little island of cortical bone within the center of the medullary cavity. The formal term here, enostosis. There are some tumors that are unique to the jaw. The most common among these is the ameloblastoma. Ameloblastoma is another way of saying that. Odontomas are tumors that are composed of tooth elements, and they come in compound and complex forms, which we'll discuss further. Cementomas are actually a family of lesions that includes the classic cementoma and other diseases like cemento-osseous dysplasia. The Pindborg tumor, or calcifying epithelial odontogenic tumor, is a rare lesion unique to the jaw. So ameloblastoma classically is a lytic lesion with multilocular or soap bubble appearance. And you can see the multiple cystic locules in this expansile mass. Ameloblastomas have a surprisingly benign appearance with expansile margins. There is a more aggressive form of this lesion called an ameloblastic carcinoma, the malignant version of ameloblastoma, but it's rare. Most ameloblastomas have this nice smooth appearance. Note the pathologic fracture in this particular patient. Sometimes ameloblastoma is unilocular. Although it's famous for being multilocular with soap bubbles, that's not always the case. If you use contrast, you'll occasionally see some enhancement inside these, but they're predominantly cystic. Odontomas are unique to the jaw because they are made up of tooth elements. They come in two types, compound and complex. Compound odontomas are formed from multiple small teeth called denticles, whereas complex odontomas are ill-formed areas of abnormal tissue that include enamel. So the only place you should find enamel is in the crown of a tooth. If you see it within a mass, that mass is an odontoma. Here is the enamel. How dense is this? It is denser than cortical bone. Nothing's denser than cortical bone except enamel. So you can see that this mass is predominantly formed of bone that is similar to cortical bone, but there are areas of enamel, a complex odontoma. Here is something that looks very similar, extremely dense material. There's some areas of enamel, but if you look closely, you can see that there's pulp and dentin, and then around the very edge, there's enamel. These are formed teeth. They're not proper teeth, but there's a jillion little tiny things that look like small teeth. These are denticles, and this is a compound odontoma. Another way that you can get enamel in the wrong places is the supernumerary teeth that we associate with Gardner syndrome. Here there are multiple teeth with enamel scattered around the jaw. Now, why isn't this a compound odontoma? Because they're not clustered together. These are individual denticles scattered around the jaw. That's indicative of Gardner syndrome. The relative fibrous dysplasia that occurs exclusively in the jaw is cemento-osseous dysplasia. This looks like areas of hyperdensity surrounded by a halo of lucency. It comes close to the teeth, but doesn't actually involve the teeth themselves. It's separated by the periodontal ligament. This is a classic appearance. It's actually much more common than you might expect if you start to look for it. It's most commonly seen in middle-aged women. Usually, cemento-osseous dysplasia is not clinically relevant, but occasionally it becomes expansile and can produce a palpable mass in the jaw. Cemento-osseous dysplasia comes in two forms, a periapical and a florid form. The periapical form is limited and occurs around one or two teeth. The florid form is when it affects all four quadrants and many teeth are involved. A similar radiologic appearance can be found with the numerous osteomas that occur in the jaw in association with Gardner's syndrome. This is a bit of a zebra, I'll admit. The Pindborg tumor, or calcifying epithelial odontogenic tumor, is a focal mass arising in the jaw with central ill-defined matrix. It looks a lot like an ossifying fibroma, but it doesn't have that stellate pattern. I think that this is one that we usually only have a definitive diagnosis once the path comes back. Although there are some lesions that are unique to the jaw, it is a bone, and all of the tumors and other lesions that may affect other bones in the body will affect the jaw as well. Things like enchondromas, or its malignant counterpart, the chondrosarcoma, schwannomas, giant cell lesions such as giant cell granuloma, brown tumor, and I suppose cherubism is unique to the jaw. That's why it's in yellow. Fibromyxomas occur more commonly in the jaw than in other locations, and of course things like sarcomas, myelomas, lymphomas, and metastases can affect the jaw. Squamous cell carcinoma is particularly prevalent in the jaw because of the adjacent mucosal surfaces. At first glance, this looks just like the residual cyst that I showed you previously, which occur after the extraction of a tooth. So let's count the teeth. Well, here's the premolars. There's 1 molar, 2 molars, 3 molars. There's the wisdom tooth. This is not a tooth socket. There was never a tooth here. So this can't be a residual cyst after extraction of a tooth. Note how close this cyst is to the inferior alveolar canal. In fact, this expansile lesion is coming off of that inferior alveolar canal. This is a schwannoma of the inferior alveolar nerve. Notice how smooth and remodeled this lucency is. Very smooth remodeled margins, characteristic of schwannoma. Hyperparathyroidism can affect the jaw as it can any other bone. This happens to be an example of brown tumor of hyperparathyroidism that happens to be affecting the maxilla. Cherubism is a giant cell lesion that is unique to the jaw. This occurs when giant cells infiltrate throughout the jaw and expand the jaw uniformly with a symmetric distribution. That's really your clue here. Destruction of the trabeculae within the jaw and expansion of the jaw, but a very symmetric pattern. That's what should suggest cherubism. A fibromyxoma is an unusual tumor that occurs in the jaw. The characteristic finding here is the dark T2 signal from the fibrous component of the tumor. The tumor does enhance uniformly, but not particularly brightly. These tend not to be overly destructive tumors. They tend to extend and expand out from the jaw. You can certainly have bone malignancies such as osteosarcoma, the hair on end or starburst pattern here, characteristic of this disease, although seen in Ewing sarcoma as well. Of course, the most common lesion that we're going to encounter in the jaw is squamous cell carcinoma, just because it's such a common disease. So what about this erosive, destructive mass is going to clue us in that this is squamous cell carcinoma and not an odontogenic tumor, an aggressive odontogenic tumor? Well, the large soft tissue mass surrounding the jaw is a good clue that this is an outside tumor working its way into the jaw. Detecting this erosion is particularly important in these patients with squamous cell carcinoma because it dramatically modifies the surgery that they will receive. Metastases can go to the jaw just like they can any other bone. This one happens to be lung cancer, although there's absolutely nothing about it that would clue me into its primary site. There are obviously many things that can mimic tumor in the jaw. Here are a few of the potentially most confusing tumor mimics. Chronic osteomyelitis, osteogenesis imperfecta, a rare disease, very confusing when you see it. The comestible intraoral foreign body, one of my faves. Surgical implants, and hyperparathyroidism, either primary hyperparathyroidism or more commonly renal osteodystrophy as a secondary hyperparathyroidism. Chronic osteomyelitis can look just like an aggressive tumor. This is destruction of bone. There's even a little soft tissue component coming out there from the chronic infection. I don't know how you know for sure that this is chronic osteomyelitis. Maybe you have some patient history. Sometimes it just comes down to tissue sampling, but always consider chronic osteomyelitis when you see destruction of the jaw. On MRI, we're looking for enhancement of the medullary cavity of the jaw. We're also looking for bright T2 signal. The normal T1 signal without fat suppression should be bright because of the marrow fat. If that gets replaced, that's usually either tumor or osteomyelitis affecting the jaw when that marrow fat has been replaced. So all of those important signs of chronic osteomyelitis. Actually, the MRI is more sensitive than the CT to early osteomyelitis. Osteogenesis imperfecta just always produces confusing CT images. This is a mass, that's a mass, that's a mass. Yeah, I suppose you could find the pathologic fractures through these lesions, but I don't think that's going to help you with this poorly healed fracture here that has produced what looks like an expansile mass. All of these are healing poorly healing fractures in the setting of osteogenesis imperfecta. These patients have a long-standing history, of course. Just another example of how confusing this can be and how much this can look like tumor instead of healing fracture. What is this lesion? It's rounded, it's the same density as bone, it's obviously some sort of exostosis. So confusing. Well, if you put it on bone windows, it's actually not made of bone, is it? It's intermediate density. And if you image in two different planes, wait a minute, it moved. It was off midline here, and now it's right in midline. This is a piece of candy. Or, if you like the more formal term, a comestible intraoral foreign body. These can be extremely confusing because they look like bone, and people often mistake them for an excrescence of bone, an exostosis of some sort. Be on the lookout. Even if you tell patients to spit everything out of their mouths, they will usually tuck their gum up into between the cheek and the gum line and hope you don't notice. So we see these all the time. Don't be confused. Similarly confusing is chewing tobacco. It often has air intercalated in. This looks for all the world like an ulcerated mass or maybe an abscess up along the inside of the lip there. But it's just chewing tobacco, a pinch between the cheek and gum. If you want to see more examples of comestible intraoral foreign bodies, check out my AJNR article with that title. It is absolutely hilarious. Favorite article I've ever produced. Implants can be confusing because they look like they might be coming off of the jaw. This is a very common implant called a mentoplasty. It's meant to strengthen the appearance of the chin for people who have shortened or weakened chin or retrognathia. This gives the chin more prominence. Mentoplasty or mental implant. Primary hyperthyroidism can be very confusing. You get thickening of the cortex and thickening of the trabeculae. It looks a lot like Paget's disease. This is primary hyperparathyroidism. Don't confuse this for a tumor or an infiltrative process of the jaw. I think the symmetry here, a good clue that you're dealing with a metabolic process rather than a tumor. Renal osteodystrophy has a classic appearance of uniform increased density of numerous bones, but among them the jaw. This could look like a chronic osteitis that might occur from chronic infection, but it is in fact kidney disease. There is a whole separate lecture on trauma, but just quickly, the jaw is famed for having multifocal fractures because it is a ring when considered along with the skull base and the temporomandibular joints. About half of jaw fractures are multifocal and about half are unifocal. They occur in predictable locations in order of frequency: the mandibular angle, the subcondylar region, the condylar neck and head, the body, the parasymphyseal region, and then dentoalveolar fractures. Again, covered more completely in the lecture on facial fractures. There is also a whole set of lectures on the temporomandibular joint. If I could give you one take-home point, it is that MRI is the modality of choice for imaging the temporomandibular joint. But check out those other lectures. There's one last topic I want to hit before we finish, and that is a tricky differential diagnosis. In patients who have been treated for tumors in their oral cavity, if that treatment includes therapeutic radiation, those patients are at risk for osteoradionecrosis. But that radiation also injures the periodontal ligament, and so those patients are at risk for osteomyelitis. Of course, we're also worried about recurrent tumor because these patients were treated for squamous cell carcinoma. Unfortunately, all three of these entities can look exactly alike. It's made even more difficult by the fact that osteoradionecrosis and osteomyelitis will frequently coexist. Each one makes the other more likely. So there's a bad downward spiral between those two diseases. So let's talk about ways that we might be able to tell these apart. Osteoradionecrosis has a permeative, aggressive pattern. There are usually little flecks of bone that get left behind in the wake as it erodes through cortical and medullary bone alike. A very aggressive appearance to an infection. I've already shown you several examples of chronic osteomyelitis and how they look like tumor, but don't forget that osteomyelitis can also produce sequestra. And so the sequestrum here is this ill-defined calcified material centrally with a halo of abscess around it and a thin rim of preserved abnormal cortex all the way around the outside. This looks a lot like an aggressive tumor, but this is just dead necrotic bone centrally. What are we going to do with this bone right here? This is actually a patient who was treated for squamous cell carcinoma of the jaw, and you can see the aggressive, irregular pattern, just like in that case of osteoradionecrosis. It would be very easy to call this osteoradionecrosis. How can we figure it out? Well, maybe the soft tissue mass that is surrounding the mandible can help us to realize that this is tumor recurrence, but I don't know, sometimes infection can also cause a soft tissue component. This turns out to be recurrent squamous cell carcinoma invading into the bone there. And this is tough, this is subtle. There's a reason that this is a classic conundrum in this particular patient population with treated squamous cell carcinoma. In conclusion, when you encounter a lesion in the jaw, there are a few features that I think will help you to classify it into one of the lesions that we've just talked about. First, decide whether it is erosive with an aggressive pattern or whether it is expansile with smooth remodeling, a more benign pattern. Then, determine whether it is a cystic lesion, whether it is a solid lesion, a hyperdense lesion, or whether it has some sort of central matrix. If it does, often the matrix itself will help you come to a specific diagnosis. Look at the distribution. Is it a unifocal lesion? Is it multifocal? Is it sitting along the root of a tooth or sitting alongside a tooth? Is it in the jaw but distant from the tooth itself? That distribution can help you to narrow your differential. Then look for unique features like the stellate pattern that we see with ossifying fibromas or the hair on end pattern of an osteosarcoma, things that might help you to come to a specific diagnosis for imaging of the jaw. This is the conclusion of the lecture on diagnostic imaging of the jaw.